I'd next like to introduce Dr. Frederick Altice. He's a professor of medicine at Yale University School of Medicine, to share his presentation with us. Thank you. Just a reminder, please do send your questions through using the Q&A app on your phone. Thank you.
I was thrilled to see that the floor did not go down below Ernst. Andrew had promised that there was a trap door at the bottom of this, and he managed to get through his 50 slides. I've only got 20, but I probably speak a lot more. And I sort of had some hesitancy in coming to the conference. I was thinking about what horrible things that my own country has done to South Africa and the rest of the world by removing the funding. Having an American coming to speak about harm reduction in prisons, of all places where the highest rate of incarceration is. And so anyway, I do want to say I'm thrilled to be here. My first time here, I met Nelson Mandela. The words that Amanda brought together and the humanity of the work that she's doing is so incredibly important, and it's really a thrill to be here. What I'm hoping to be able to do is to really cover 3 topics. One of them is very quickly the coverage of harm reduction in prisons. And I will point to 2 presentations. Right after this, Louisa Degenhardt is doing a global a systematic review. And then later this afternoon, Tom Santo is doing a presentation on coverage of the epidemiology and the coverage of services in prisons. Then I'm going to talk about just a few innovations in harm reduction in prisons. 20 minutes, as Ernst pointed out, you just can't get through it all, but you can get through some of it, and many posters and presentations, which are really wonderful here. And then I'm going to talk about the transition from prison, and Amanda sort of got through some of that. In a review in the next session, one of the key things is we have to sort of think about our prisons as part of our public health system. These doors are incredibly porous. They're like porous membranes. People move into and out of them. And the laws and the regulations and the social determinants of health are the things that drive people who are at highest risk. So if you think about sort of the famous bank robber Willie Sutton in the US who was repeatedly sort of robbed banks, and he came up to the judge, and the judge finally said, "Willie, why do you keep robbing banks?" And he said, "Well, that's because that's where the money is." So if you want to think about doing a lot of work that's really going to be good for society, where there's a great concentrating effect, this is where a lot of the work is. And so you can see that among the about 12 million people who are incarcerated, which represents about 30 to 50 million people who pass through there, there's an incredible opportunity to do the work. But unfortunately, the coverage, and from the slides that Ernst provided, are really sort of markedly lower. And so there's this concentrating effect, but yet less coverage of services that are within these particular settings. The good news is that we have an incredible toolbox of things that we can potentially bring to do the work that we hope to do. I would say first and foremost, we should really focus on decriminalization and decarceration. We have some good examples and some not so good examples around that, but that work should not stop. But in the absence of those kinds of policy changes and shifts in the way that governments do their work, we do have some tools that we need to implement. And there's no time like the future. I think Ernst said it, just put your foot in the door and get the work going, because there's no place to start but right at the beginning to do this sort of work. We have antiretroviral therapy and PrEP. We have incredibly low coverage all across the globe with regard to that, so treatment as prevention. The same is true for direct-acting antivirals for hepatitis C. We have our supervised injection sites, or drug consumption rooms that they're referred to. Ernst talked about that. We have 2 places in the globe that have those in prison, so we're making progress and making some sort of steps forward. Syringe services programs, you call them NSPs, NEPs, they're all the same sorts of things, depends on which part of the globe you're coming from to use that sort of terminology. Our opioid agonist therapies, and then I will say that we really need to sort of move the shift the field with regard to overdose education and naloxone distribution. And then, of course, I was reminded yesterday that I did not talk about condoms in the pre-conference work, and so that is all part of our harm reduction, and it's an important part. And I'm going to give you an example of Moldova, who I think that does a really good comprehensive job at covering a lot of these sorts of things. And then, of course, that dangerous transition from prison is incredibly important. A systematic review that looked at this, what's really interesting is that a lot of the data around the effectiveness of the interventions that we have in prisons, there's just really a huge desert. There's just a lot of stuff that's not out there. But where there are data, really essentially this is a large systematic review by Crystal McDonald, 126 studies, over 500,000 people from within these studies. And there's a little bit of data that really suggests that there's some benefit from these therapeutic communities in reducing reincarceration and a small amount of drug use, but really sort of very sparse and limited with regard to that. What's really important is that these psychosocial interventions, they really don't work in these settings. You need a medication for many of these sorts of things. Whether that will pan out with some of the stimulant use is unclear, but there are medications potentially on the horizon that I want you to be thinking about and looking forward to in the future. Educational programs with regard to HIV and hepatitis C, that motivation to go on to treatment has some evidence of a small reduction in treatment. And then unfortunately, we haven't built the body of data, even though we know that naloxone works. We don't have to have a clinical trial to show that, but we just don't have the data for that yet with regard to the services. I will say that the best and the most definitive and cross-cutting behaviors, risk behaviors, and drug use, et cetera, is for opioid agonist therapies, for which there's the greatest data both within the prison but also after release. And then syringe services really has a number of positive benefits, most specifically with regard to needle sharing and injecting drug use. And so we've got some fairly good data. So we do have some data there, but the data that works in the community works in prisons. The big problem is that the implementation in many places has a lot to be desired. And so I'll just go over a couple of slides that Tom will actually go into more detail. This afternoon at 1 o'clock in the afternoon, is that Ernst really talked about the numbers about the global coverage for what's available in the community. Even though the need is greater, the risk is greater within a prison, those numbers are actually much lower. And even among the 59 countries that have opioid agonist therapies within the prison, they may oftentimes just be a single setting and not really good coverage across the area. The same is true for syringe services programs within prisons. There's only 10 countries in the world. There have been a few countries that have dropped out. I will put a shout out to Ukraine, which is the most recent place that's done that. I think we have some colleagues in the room. There they are over there. Those are some of my heroes. Ukraine introduced opioid agonist therapies at the beginning of COVID. This is a country that is committed to really those who are the furthest away, the folks that Nelson Mandela said that we should be doing this sort of work with. But not only did they do that, but during the war, they introduced their first syringe services programs. And so this is a place that values the people who are at the periphery of our society, even in the midst of a war where they are just trying to keep people alive in their setting. Now, what's not only important is whether you get a check mark in each of these countries, but what does that coverage look like, across these various different settings? And so, what we can see is that if you take a look at the sort of the WHO and UN targets, only about 2% of people are getting all of the sort of the harm reduction services that we're sort of hoping to be able to get into people and make accessible to those with lived experiences. And so we're really quite far. But one of the problems that we have is how do we think about putting these implementations into this context? And in implementation science, context is almost everything. We have to think about where we are. And this is a risk environment that is heightened, but it also has a different governance system with the way that we do this sort of work. This is a particular framework. There's a bunch of them out of there, but the key thing is that we really have to think about the stakeholders who are involved. We have our clients, the person that we are hoping with a lived experience who we can basically have buy into and to participate in the setting. We've got their peers who may have influence, such as gangs or these prison hierarchies who really negatively influence the way that services are delivered, especially in places like Eastern Europe and Central Asia. We have the people who provide the health. We have the custodial people who have the keys to the cells. We have the leadership who may or may not have the executive sponsorship to be committed to doing the work in our sort of structural regulations. But what I will say is that as you begin to assess this, these particular stakeholders may be at odds with each other, and coming up with the places where the Venn diagrams come together is a really important part of that effective implementation. I will say that this is one particular model for thinking, through this is, so think about what the evidence practice gap is. In prisons, it's huge. I mean, there's a few places that have services across all the institutions, for instance, with OAT and syringe services programs. Spain gets sort of a big, sort of shout out with regard to that sort of work. Moldova does a pretty good job with regard to that. But thinking about what are the key components of the practice, the evidence-based practice. How is it accepted by the various different stakeholders? What are the barriers, and what are the strategies that you put in place to overcome those barriers? If the prison officers think that this is, the worst thing, that they've ever could have imagined, sometimes they just need some education. So educational programs may be part of that, but also making things less complex, opportunities to reduce a reinforcing stigma under these circumstances, providing things in places where people can access the services without having the peer influence. And then you have to evaluate it. Anytime that you introduce a program, it's not about just starting it up and you have a good protocol and everything's done. It's always about constant reevaluation, because there is always going to be an implementation gap in the way that we do our work. Now, one of the challenges is that we oftentimes will put up some guidelines or the ways to do the work, and we think we're done. We've got a program, we've got a check mark. And that's what we call letting it happen. We put it in there. But really what we have to always be thinking about is setting the target. So if we have 1,000 people in our facility, and then we have 200 of them who are people who have or do inject drugs, that becomes our new sort of target. And oftentimes, and it doesn't matter whether you're in the community or in the prison, we very seldom get to close those implementation gaps. And so what we have to do is we have to think about what that gap is, what is it that we want to measure, and then by implementing, by doing things different, really requires these constant changes. So whenever you get something codified in law, and this is your protocol, you're stuck. So I would often say, don't ever allow that to happen. Set your targets and do your work, and then do process evaluation to sort of make it happen as opposed to letting it happen. An example, as we sort of think about the work that we're doing, you might actually have, we're going to hear a lot this week about pilot programs, and a lot of the data that comes out of prisons is oftentimes pilot projects. So you have to get a place to start. So you got to get the foot in the door. You've got to do that sort of increased work. And then we have to sort of, even within a prison, let's say, oh, we're excited. We've got 18 people on opioid agonist therapy, but we need to get 200. And so how do you actually improve the quality of the work? The best way to sell implementation is to have a quality program, one that is low in stigma and easily accessible, and really without a lot of hurdles for people to go through. What happens with that is you can actually increase reach, so you can reach more people within that prison. When things are successful, you can take that and you can sort of move it to greater adoption within a country so that you can spread it out. There is a sort of an infectious consequence to that, where you can actually move it out into other sorts of settings. And you sort of think about it in the last 20 plus years, when since prisons have adopted syringe services programs, we've actually lost more. And we've only had one new site in the last 10 years. So we have to think about, how do we improve the quality of these kinds of services so that, one, the people who are the stakeholders are more likely to use the service, and the people who are looking from the outside are more likely to adopt that elsewhere, so that we have greater diffusion. I'm only going to talk about a couple of innovations in harm reduction in prisons, just because you all are doing the really important work, and I really want to congratulate Amanda on her award and the work that she's doing in British Columbia. This is the kind of work that I hope to see more and more people doing. I've had the good fortune of being allowed to come into prison and being released on good behavior for 40 years. And so that's a good thing to be able to do, but I'm so excited to see so many more people who are doing some of this really important work. I'm going to use Moldova as an example. I've been fortunate to be able to work in Eastern Europe and Central Asia, which is really a tough place to work. And Moldova has been sort of a beacon for a lot of this work. They introduced syringe services programs early, late 1990s, early 2000. They went on, they put methadone as a pilot, so the installation, that single dot on that last map for an example. And then between 2008 and 2014, they really expanded it to 13 out of their 17 prisons. So once you have this sort of the expansion, so that's the model for this kind of work. In 2000, just a couple years later, the Ministry of Health adopted this as part of their national guidelines. They were able to fund it on their own independently. So, you know, and it was because the Global Fund and these other sorts of services were reducing the funding. And so necessity becomes the mother of invention, and methadone is cheaper, and so they came up with ways to do it more cheaply. It was expensive to transport it. They shifted to other alternatives for treatment. They've introduced and they've added on buprenorphine, and they're now looking at long-acting sort of buprenorphine. With their syringe services programs, they also introduced condom distribution. And what they've done is they said, all right, well, we got to a certain place within these facilities, but how do we make it so that there is greater reach within it? So it was initially a medical model. I've got news for you. If you're injecting drugs in a prison, you're not going to go up to the doctor and say, can I have a syringe? You might go and ask for a medication, but you're not going to ask for that. And so they said, well, let's see if we can do something a little bit different. They wanted to reduce the contact. So during COVID, they said, let's put up some vending machines so you can just sort of walk around a private corner, you know, in many places within the facilities and go in there and get your, you know, your syringe or your condoms or whatever lubricant, whatever it is that you need. And there's an array of sorts of things. I also think that they should probably put a couple of candy bars in there as well so that you can say it's for the people who are getting candy bars, but they're not quite there. I was able to make a site visit just recently. And then what's really exciting is that they've actually taken this one step further, and they've got peers who are in the units where people can just walk into their room, and you know, the people who run these, they get a sort of a specialized area where they've got a little bit more space and maybe a little bit more food. But their job is really to make sure that people get it. And they've actually shifted their coverage of all of these services so dramatically by putting it in the hands of peers. So this is an example of an evolution. Now, should it take 20 years to get there? The answer is no, but these are the kinds of services that one can sort of look at. And then more recently, within the last year and a half, they've actually expanded the services to all of the facilities, including in some of the area that's occupied by Russia in the Transnistria sort of area of the country. Now, I want to say that, you know, oftentimes we want to think about creating the evidence, and so we want to do these sort of these prospective double-blind, you know, trials in order to prove the outcome, and oftentimes they're done at the individual level. But I would say that we're really looking at a systems issue, and we need to rethink the way that we do this sort of work. This is a really good, you know, conceived trial, at least in principle. You know, it's a double-blind, randomized control trial of take-home naloxone that you give to someone right as they're transitioning to the community, with the idea that they will actually reduce overdose. Well, one of the problems with these things is that policies change, things shift. You spend 2 or 3 years coming up with the perfect protocol in order to get the work done. And there were sort of some policy diffusions in terms of making it sort of legal in many places. There were spillover effects because there was going to be cross-contamination. It was underpowered for something that was called overdose in the person who actually got it. But in reality, what happened is that over 50% of the naloxone usages were done to save somebody else. And so anyway, this trial was stopped for efficacy and ethical reasons and stuff like that. But I think that it's really the takeaway is that we should really be thinking about how do we get more medications into more people's hands, get them to make sure that they walk out the door with it, and whether they use it on someone else. So it's really about maybe perhaps the fidelity to getting it to them and getting it into more people's hands. I'll give you an example of what I call a more practical way of sort of thinking about this, and this is done in 6 jails in Michigan. And what they did was they just shifted the whole program by moving to vending machines. And so they said, we're going to do things differently. And compared to having to come up and talk to somebody and go through the process, making it a voluntary process, they increased the access by 63%. And I've got news for you. We don't have to prove that naloxone works. We just don't. We just need to make sure we get it in the hands of the people who need the sort of work. Let me just talk about just a couple of innovations in transition from prison. I still think that there's a trap door below here, and I've got 2 minutes to do this. And really want to talk about, this is really, really a dangerous period. Amanda hit right on it on her person who died at 10 days afterwards. The peak period is the first 7 days after release. And so that transitional process has got to be planned for from the time that a person walks into the facility. Discharge planning happens from the very first step, and so we have to do better. And what most people die from is from alcohol and drug overdose and suicide. All right, so we have to think about how do we plan that later on down the road, a year later, cardiovascular disease and cancer. Here's a prospective trial of patients who were either, some of them were randomized the first 67, most of them they had a preference. I think Ernst said, ask them what they want. We changed the trial so that they actually would be able to choose what they want. And as you can see, that it's not just whether they get methadone, but it really matters that they're getting a therapeutic dose. If you have a diabetic patient, you don't just give everybody 5 units of insulin, you want to actually control it. So higher doses are more likely to have a benefit. What you can see is you get a 20% change in your implementation gap by doing that alone. So you're actually having an effect with regard to that by just giving them a quality dose. And I can tell you across the globe, the average dose of methadone is usually between 40 and 50 milligrams in prisons, and we are far away from doing this. But this is a simple solution, getting the dose up to something that's equivalent. Now, what was important in this trial is that for the people who were in the trial, for those who, in all of them, all 212 of them had HIV infection, and what we found is that if they got the methadone, not only did they have a better linkage to care, and retention and care, but they were also more likely to jumpstart the HIV treatment cascade by getting linked to their HIV care right after release. And so this is a really important outcome that you have the benefit of two, if you will. And I think Ernst and almost every speaker today has talked about the complexity. We don't have patients with a single condition. There are sort of multi-morbidities that we're dealing with, the social determinants of health, some of which we can't fix right away, but we can do the things to keep them stable so that they can have a safe transition to the community. This is my last, I'm off the stage. The bottom line is this is the first study that I've seen looking at PrEP, trying to get people out. There's major implementation gaps. You have to figure out where the gaps are if you're going to actually change what you're doing. And you can see that the gaps are really about sort of, most of them were eligible. They didn't get the prescription because of all the laboratory effects and stuff like that. They were released too early. So just give it to them, put them in their hands, and when they get released, they're gone. There are some solutions to some of these sorts of things. And then even for the small percentage who did initiate the PrEP, they didn't get linked to services because we didn't have those services in place. So I'm not even going to go through the summary because you're going to see the rest of them. But the bottom line is lots of disease, it's concentrated, much lower coverage, and we have to bridge the implementation gap. Thank you so much.